Assalamu alaikum. Hello everyone, this is Mohamed Mamdouh Abdalbary and it is a pleasure to give this small presentation about ANCA associated vasculitis from renal perspectives. So ANCA associated vasculitis is a necrotizing inflammation of small vessels. It usually begins in the 5th to 7th decade of life, but it may occur at any age. There is a slight male predominance and it occurs more in whites. Usually, it involves glomerular capillaries causing glomerulonephritis, pulmonary capillaries causing alveolar hemorrhage, and dermal venules causing vasculitic rash or purpura. ANCA-associated vasculitis is a relapsing disease. This means it will need a maintenance therapy. It is a post-immune vasculitis, which means there is a few or no deposition of immune complex, and instead it is associated with circulating anti-neutrophil cytoplasmic antibodies. And as regarding the pathogenesis, we can see here this is the neutrophil, unstimulated neutrophil, and it contains the ANCA antigen inside of the neutrophil. But when this neutrophil is primed by cytokines, this antigen moves to the surface and it binds to the ANCA. So the ANCA binds to the ANCA antigen, and this will cause the FC and Fab part to bind the ANCA antigen complex, and this will cause a neutrophil activation, and this will cause activation of the alternative pathway of the complement, resulting in amplification of the inflammation via C5a. At the end, there will be apoptosis and necrosis of neutrophils and endothelial cells. So ANCA-associated vasculitis is a part of small vessel vasculitis, and it can be categorized into 4 categories. First is eosinophilic granulomatosis with polyangiitis, previously known as Churg-Strauss. Second is granulomatosis with polyangiitis, previously called Wagner disease. And third is microscopic polyangiitis. It is a microscopic polyangiitis and renal remitted vasculitis. So in eosinophilic granulomatosis with polyangiitis, we can have a granuloma or granulomatous inflammation, and this patient usually have asthma or eosinophilia. In granulomatosis with polyangiitis, we have only granulomatous infection. In microscopic polyangiitis, we don't have granuloma nor asthma. We have only angiitis or inflammation. In renal limited vasculitis, there is absence of systemic vasculitis, and all the 4 categories, they have the similar feature on kidney histopathology. But remember that small vessel vasculitis is not only about ANCA-associated vasculitis. You could have immune complex associated vasculitis like cryoglobulinemic vasculitis, Nextion-Lyme purpura, lupus vasculitis, rheumatoid vasculitis, vasculitis associated with Behçet disease, drug-induced or infection-induced or paraneoplastic or Anit-GBM disease or IBD vasculitis, and you should have all these vasculitis in your mind when you have a case of a small vessel vasculitis. So about the clinical features, ANCA-associated vasculitis usually start with non-specific prodroma like fever, malaise, anorexia, weight loss, myalgia, and arthralgia. So these patients frequently misdiagnosed as they have infections or malignancies or inflammatory disease. The kidney is affected in ANCA-associated vasculitis, so the patient could have asymptomatic hematuria. They could have variable degree of proteinuria, but it's usually subnephrotic proteinuria, and in most cases the patient could present with rapid progressive glomerulonephritis. That means the patient's serum creatinine is increasing rapidly during a short duration, and the patient could present with oliguria, and he could be dialysis dependent. About 18% of patients will present with kidney problems at presentation, but 77% will present with kidney manifestation within the 2 years of onset of the disease. The kidney affection is less severe in eosinophilic granulomatous with polyangiitis, the Churg-Strauss disease. It affects the upper and lower respiratory tract infection, so it can affect the ENT. Usually, this is more common with granulomatous polyangiitis, the Wagner disease. You can have sudden nose deformity or upper airway or retroorbital mass, or you can have granuloma. And it affects the lung, the lower respiratory tract infection, causing alveolar hemorrhage with increased risk of death or sometimes it causes lung nodules, or occasionally tumor-like masses. Sometimes it causes tracheal or subglottic stenosis, consolidation, fusion, or even interstitial lung disease complicated by pulmonary artery hypertension. The patient could have neurological manifestation, that means in the form of mononeuritis multiplex, and it is associated with worse prognosis. Sometimes the patient could present with foot drop or wrist drop. The patient can sometimes have hearing loss, and he sometimes have CNS mass lesion in rare cases. Usually skin manifestation present in 30 to 50%, and the most commonly the patient could have purpura of lower limb, and it could be accompanied by necrosis and ulceration. And this manifestation may include urticaria, livido reticularis, nodules or erythema nodosum or pyoderma gangrenosum. Less commonly, the patient can have GIT, heart, or lower genitourinary tract infection or affection, parotid gland or thyroid, liver, or breast or DVT. Remember that kidney may be affected without extrarenal manifestation, and vice versa. That means the patient can present with extrarenal manifestation without kidney problem. But remember that 77% of patients will present with kidney disease during the first 2 years of presentation. So as regarding kidney pathology, so kidney biopsy is the gold standard with diagnostic accuracy of more than 90%. So kidney biopsy always to be considered, but should not delay the initiation of treatment. The classic presentation of ANCA-associated vasculitis is segmental fibrinoid necrosis, here is the fibrin, and necrotizing glomerulonephritis, usually with crescent. So it could be non-proliferative, but it is necrotizing glomerulonephritis, and you can see it is a crescentic here. And this is often accompanied by tubulo-interstitial inflammation or infiltration, and in the immunofluorescence there would be few or no immune deposits in the immunofluorescence and electron microscopy. Occasionally it can have immune complex deposition, but in rare cases, or it could have overlap with Anit-GBM, with membranous nephropathy, with any other glomerulonephritis. There is a histopathological classification of ANCA-associated vasculitis, and this graph is from KDIGO guidelines. So if you have more than 50% of globally sclerotic glomeruli in the kidney specimen, so it is a sclerotic class and it is poor outcome. If you have more than 50% of the glomeruli are normal, so it is a focal class and it is a good outcome. And if you have more than 50% of glomeruli has cellular crescent, so it is a crescentic class. And if you don't have any of these or those, it could be a mixed class, and there is discrepancy in the outcome of the mixed and crescentic class. So what is the role of ANCA assay in ANCA-associated vasculitis? So ANCA can be detected by two methods. The first is immune fluorescence assay, and it can give us two major staining patterns. The C ANCA, which is cytoplasmic ANCA. So you can see the staining here in the cytoplasm, and B ANCA, which is a pre-nuclear ANCA, and the immune fluorescence assay is more sensitive. Or you can detect the ANCA assay in the serum by ELISA, by enzyme immune assay. So C ANCA have a specificity for BR3 or proteinase 3, and B ANCA have a specificity for myeloperoxidase. So if you are getting confused with this, so C ANCA was 3 and B ANCA was MBO. And the ELISA technique is more specific. So the optimal approach is to perform both the IFA and ELISA. So ANCA assay is sensitive. It has a good sensitivity, about 80 to 90%. But remember that 10% of patients are persistently ANCA negative. So negative assay does not exclude ANCA-associated vasculitis by 100%. And remember that ANCA status may change over time. So if the patient could be negative at the start of the disease, but it may become positive upon development of generalized disease. The ANCA assay lacks specificity, especially by IFA. It could be falsely positive in up to 25% of patient with lupus nephritis, or idiopathic immune complex crescentic glomerulonephritis, or post-infectious glomerulonephritis, membranous nephropathy, IgA nephropathy, IBD, or rheumatoid disease. And there are many drugs which can cause ANCA-associated vasculitis, and it would be usually MBO ANCA, like hydralazine and propylthiouracil, methimazole, carbimazole, minocycline, allopurinol, benzylamine, broquinamide, and phenytoin, rifampicin, cefotaxime, and isoniazid. And remember that levamisole contaminated cocaine can cause also ANCA-associated vasculitis. In some cases, there is an overlap or double positivity between ANCA and anti-GBM. 25% of patients with anti-GBM crescentic glomerulonephritis, there are also ANCA positive. And those patients, they have a prognosis which is between ANCA and anti-GBM. So it is worse prognosis than ANCA-associated vasculitis alone, but it could be better than anti-GBM. And the important thing is those patients need maintenance therapy. So the patient who is only anti-GBM disease, they don't have maintenance therapy. The anti-GBM is not a relapsing disease. But if the patient has double positivity, it will need maintenance therapy. So what is the role of ANCA assay in differentiating between ANCA-associated vasculitis subtypes? So granulomatous polyangiitis, 70% of them will have BR3 ANCA. In MBA, there is equal distribution between BR3 and MBO, and eosinophilic granulomatous polyangiitis, the Sjorg-Strauss disease, has the lowest overall frequency of all ANCAs. Renal limited vasculitis, 70% will have MBO ANCA. Changes in ANCA titers over time modestly correlate with disease activity. So increase in ANCA increase the likelihood of relapse, and it can precede the relapse. And the achievement of ANCA negativity after induction is associated with lower risk of relapse. However, again, this is only modest, and the ANCA measurement should not solely guide the treatment decision. So, in case you find a patient with RBGN or rapid decline in kidney function, you should do a urine analysis. So, if the urine analysis is positive for proteinuria and RBCs, if yes, so you could have, is it glomerular or not? You can do phase contrast microscopy. If yes, consider rapid progressive glomerulonephritis, evaluate for extrarenal signs or symptoms, obtain serology for ANCA, for ANA, for anti-GBM, for complement, exclude infection, and obtain kidney biopsy. And in case you have clinical presentation, as we mentioned before, plus positive serology of ANCA, don't delay starting immunosuppression waiting for kidney biopsy result or waiting for doing kidney biopsy. So start the treatment as soon as possible. So what is the evidence we have in treating patient with ANCA-associated vasculitis? We have a landmark trial, ANCA-associated vasculitis, and these landmark trials, they shaped the guidelines we have today. So we have a landmark trial for induction and for maintenance, and we are going through the most important of them. So for induction, starting from 1970, cyclophosphamide and glucocorticoid were found to be effective in treating patients with ANCA-associated vasculitis. In cyclopus in 29 or in 2009, they compared oral versus IV cyclophosphamide and found that IV cyclophosphamide had a lower rate of leukopenia, a lower rate of infection. No difference was found in renal or overall survival, but there was a higher relapse with IV cyclophosphamide, but this relapse could be related to the higher cumulative cyclophosphamide dose in the oral group. We have the REF trial in 2010 and 2010. They compared the rituximab versus cyclophosphamide, and the rituximab was not inferior to cyclophosphamide for treatment of neo-onset ANCA-associated vasculitis. And in subgroup analysis, there was a superior remission rate for patient with BR3 ANCA, but similar remission in MBO ANCA. So this means that if you have a patient with BR3 ANCA, preferably you could use rituximab. But in the RAVE study, they exclude sicker patients, so patient with alveolar hemorrhage, or patient on mechanical ventilation, or patient presented with creatinine more than 4 mg per deciliter, they were excluded from the study. Then we have the rituximab in 2010 again. So they used the rituximab weekly for 4 weeks and added to it 2 IV cyclophosphamide pulses versus IV cyclophosphamide for 3 to 6 months plus maintenance with azathioprine. And they found that the two regimens were similar in induction, remission, and adverse event, and the rituximab included this time included sicker patient with creatinine more than 4. So based on the RAVE and rituximab in 2010, in April 2011, rituximab was FDA approved in treating patients with ANCA-associated vasculitis. So what evidence do we have about plasma exchange? We have the VIX study in 1990 when they compared plasma exchange plus immunosuppressive drug versus immunosuppressive drug alone. So adding plasma exchange provided benefit only to dialysis dependent patient, and this difference was less pronounced during 12 months follow-up period. Then we have the MEPIX trial in 2007. So they compared the plasma exchange versus pulse steroid, and they found that there is an improved kidney outcome in patients with severe kidney disease with serum creatinine more than 5.7. Again, longer follow-up showed that this difference disappeared after 12 months for end-stage kidney disease and mortality. Then we have the Bixivas in 2020 when they compared plasma exchange versus no plasma exchange. And this time, plasma exchange failed to delay the time to end-stage kidney disease or death for patients with GFR less than 50 or patients with alveolar hemorrhage over a median follow-up of 2.9 years. But in the Bixivas trial, they also compared two regimens of steroid and found that lower dose steroid protocol was comparable in efficacy to standard protocol. So to summarize this evidence, plasma exchange could be beneficial to patients with dialysis dependent, with patients with severe kidney disease, but this effect is decreased over time. So after 12 months, there will be no difference for end-stage kidney disease or mortality. And we have the MyPsych, where they compare the MMF versus cyclophosphamide, but only in non-life-threatening disease. So they excluded patients with progressive renal disease, and they found that MMF could have similar remission if you started the patient with MMF versus cyclophosphamide, but there is increased relapse in the R3 ANCA. Again, methotrexate with glucocorticoid has been used for ANCA-associated vasculitis without kidney disease, but again, this is in absence of irreversible tissue damage and in absence of kidney disease, and this was associated with a higher relapse rate and a higher occurral of damage compared to cyclophosphamide. So what evidence do we have about maintenance? We have the psych as a REM in 2003. So basically, all patients have cyclophosphamide for induction for 3 months. Then those patients were divided either to continue cyclophosphamide for 12 months or stop cyclophosphamide and maintained on azathioprine for 18 months. And they found that azathioprine was equal in preventing relapse with less leukopenia compared to cyclophosphamide. And based on this study, azathioprine has become the cornerstone treatment of maintenance until it was challenged. We have the WIGNET trial in 2008. So methotrexate compared in azathioprine, but again in patients with GFR more than 60, and they found that they were comparable. And we have the improved trial in 2010, azathioprine versus MMF, and MMF was less effective. That means that patients they have higher relapses compared to AZA, and both has similar side effect. Then the rituximab, we have studies about rituximab, comparing it to azacitidine. So we have the MNDU trial in 2014 when they compared azacitidine to rituximab. And they found that rituximab decreased the major but not minor relapses, and there was no difference in side effects. And both groups used cyclophosphamide for induction. But in RED-AZARIM trial in 2020 or 2020, they compared azacitidine versus rituximab, and they found that rituximab decreased the major and minor relapse in patients with history of relapsing ANCA-associated vasculitis. Again, no difference in side effects. And in this study, they have a group who have induction with cyclophosphamide and a group who have induction with rituximab, and they found that following induction with rituximab was superior to azacitidine for preventing relapse in patients with previous relapses. And we have MNRITSAN 2 and 3. So MNRITSAN 2, they compared the fixed doses of rituximab versus tailored rituximab doses with monitoring of CD19 for depletion of B cells and ANCA titer, and they found that no difference in relapse or adverse event, but the number of infusion was reduced in the tailored group. And in MNRITSAN 3, they tried to answer the question, should we continue rituximab after 18 months? And they found that rituximab after 18 months decreased the relapse. So azacitidine has been the standard maintenance therapy over the past several years. Currently, this has been challenged by rituximab. So what about the duration of immune suppression? How long that we give immune suppression? In REMAIN trial in 2017, they found that continuing azacitidine plus glucocorticoid for 48 months it was associated with lower relapse and better renal outcome, but higher side effect compared to withdrawal after 24 months in patients with remission. And we have a new trial about the Avacopan, the advocate trial in 2021, and we are going to talk about it later. So Avacopan is oral C5a receptor antagonist. Remember the first picture that we see in I think on the second or third slide about the pathogenesis of ANCA-associated vasculitis. So the complement 5a has an important role in promoting the neutrophil activation and in the ANCA-associated vasculitis pathogenesis. So Avacopan is an oral C5a receptor antagonist. They compared it versus prednisolone after induction by rituximab or cyclophosphamide. And at 26 weeks, Avacopan was not inferior to glucocorticoid, but at 52 weeks, Avacopan was superior to glucocorticoid. So, to have the guidelines in summary, for induction phase, you can start with glucocorticoid plus cyclophosphamide or rituximab. So for glucocorticoid, patients with RPGN or alveolar hemorrhage typically receive pulse methylprednisolone 500 to 1000 milligram daily for 3 days. In patients with markedly reduced kidney function, it means creatinine more than 4 or rapidly declining GFR, cyclophosphamide plus glucocorticoid are preferred. Also, rituximab plus cyclophosphamide can be considered. Glucocorticoid plus cyclophosphamide induces remission in about 75% of patients at 3 months and 90% of patients at 6 months. And the choice between IV or oral cyclophosphamide is according to availability, cost, and adherence. In some patients, you could prefer rituximab. That means you can prefer it in children and adolescents because they could have, if you give them cyclophosphamide, it would have a long cumulative dose or a large cumulative dose. And rituximab is preferred in patients who are concerned about their fertility because we know that cyclophosphamide has a side effect and it causes infertility with very large doses. In frail older adults, you can use rituximab if you are going to use glucocorticoid sparing therapy. If you have a patient with relapsing disease, or if you have a patient with BR3 ANCA, because this patient also they have more relapse, you can use here rituximab. But you can prefer cyclophosphamide if you have a patient with severe glomerulonephritis with serum creatinine more than 4. And in this point, you can either use cyclophosphamide or you can combine 2 IV pulses of cyclophosphamide with rituximab. And about the doses of immune suppression, so if you started with oral cyclophosphamide, you can have the dose here. It is 2 milligram per kilogram per day for 3 months and continue for ongoing activity for a maximum of 6 months. And you should use this dose for age and for GFR. If you started with IV cyclophosphamide, it is 15 milligram per kilogram at weeks 0, 2, 4, 7, 10, 13. 16, 19, 21, 24 if required. And you should also reduce this dose for age and for GFR. If you are going to use induction for rituximab, you can use either 1 gram at weeks 0 and 2 or 375 milligram per meter square per week for 4 weeks. If you are going to combine rituximab and IV cyclophosphamide, you can use either any doses of rituximab, either the 375 or the 1 gram with cyclophosphamide 15 milligram per kilogram per dose. And if you are going to use MMF in patient with non-threatening ANCA-associated vasculitis, you can use the usual dose of 2000 milligram per day, and it could be increased to 3000 milligram per day. So what about plasma exchange? Consider plasma exchange in patient with severe presentation, the patient who have serum creatinine more than 5.7, especially if he is oliguric, or patient who is dialysis dependent, patient presented with alveolar hemorrhage and hypoxemia, patient who have overlap syndrome of ANCA and Anit-GBM. And regarding the dose of plasma exchange, so if it is ANCA with severe kidney disease, you can have 7 treatment over a maximum of 14 days, which means that you have day after day. And if you have a diffuse alveolar hemorrhage, so you have to do the plasma exchange daily until the bleeding stops and replace albumin with fresh frozen plasma. If you have vasculitis in association with Anit-GBM, so you have to do the plasma exchange daily until Anit-GBM are undetectable for 14 days. So discontinue immune suppression after 3 months in patients who remain on dialysis and don't have any extrarenal manifestation of the disease. So this patient would not benefit from immune suppression. So what about maintenance? You can use either rituximab without glucocorticoid or azathioprine with low-dose glucocorticoid after induction of remission by cyclophosphamide or by rituximab. So the EULAR or the ERA-EDTA, they prefer azathioprine over rituximab, and they advise maintenance therapy for at least 24 months following induction. But the KDIGO, they prefer rituximab for maintenance therapy, particularly for patients with non-relapsing disease, patient with BR3 ANCA-associated vasculitis, patient who have azathioprine allergy, or patient who have induction with rituximab. However, some caution should be exercised. KDIGO has not advised the fixed duration of maintenance, but interval of 18 months to 4 years following induction, tailored according to the risk of relapse and the drug used for maintenance. In some patients, you can prefer the rituximab in patient with relapsing disease, patient with BR3 ANCA. If you want to use glucocorticoid sparing drug, if the patient is very frail and old, you can prefer rituximab. But if the patient has low baseline IgG, or if the patient is hepatitis B, or he has hepatitis B surface antigen positive, or there is limited availability or higher cost of rituximab, you can prefer azathioprine. There is no rule for routine use of oral glucocorticoid with rituximab maintenance, so rituximab in maintenance usually used alone. Methotrexate considered for maintenance therapy for those who are intolerant to azathioprine and MMF, and if the GFR more than 60 ml per minute. In MBO, ANCA-associated vasculitis after induction with rituximab, maintenance sometimes could be avoided because the risk of relapse is low, but this patient have to be monitored intensively and risk of relapse should be considered, and the patient should be informed for the need of attention if symptoms recur. And you can see here the doses for drugs for maintenance therapy for rituximab. So you started with 500 milligram for 2 doses at complete remission, then 500 milligram every 6 months. So there are 3 doses, and this is the main Ritsen scheme. Or you can use 1 gram infusion after induction of remission, and 1 gram at 4, 8, 12, and 16 months. It means that every 4 months after the first infusion, and this is the ERA-EDTA scheme. If you are using azathioprine, you would start with 1.5 to 2 milligram per kilogram per day until 1 year after diagnosis, then decrease by 25 milligram every 3 months. If you used MMF, as we previously mentioned, you could use 2000 milligram per day. So about glucocorticoid, dose of oral prednisone is 1 milligram per kilogram per day in the first week. Some patients would start with pulse methylprednisolone, those who are presented with RPGN, alveolar hemorrhage, or severe disease. Then you could have a withdrawal of glucocorticoid. Following cyclophosphamide induction, oral prednisone should be reduced to a dose of 5 mg per day by 6 months. And following rituximab induction, prednisolone can be withdrawn at 6 months. The reduced dose regimen of glucocorticoid was non-inferior, as we mentioned before, to standard regimen with respect to death or end-stage kidney disease, and there was a reduction on severe infection in the first year with the low-dose glucocorticoid group in the BIXVAS study. Remember that low-dose trimethoprim sulfamethoxazole is advised for pneumocystitis, pneumonia prophylaxis for the duration of cyclophosphamide course, and for 6 months following rituximab induction. And longer-term use may be considered in those receiving repeated rituximab infusion, or those who have structural lung disease, or those requiring ongoing immunosuppression or glucocorticoid therapy. Immunoglobulin level before rituximab should be checked, because if this level is low before rituximab, this means that this patient could develop hypogammaglobulinemia. And a low level at baseline may predict a greater risk of secondary immune deficiency. And the patient in ICU, those who are receiving mechanical ventilation, they have high risk of infection and death. So you should avoid leukopenia in this patient. And sometimes you can use plasma exchange and high dose IVIG. So this figure is from KDIGO. So if you have diagnosis of ANCA-associated vasculitis, assess the disease, you should start with induction of remission with cyclophosphamide plus glucocorticoid or rituximab plus glucocorticoid. If you have no organ-threatening involvement, you could consider MMF. And if you have vital organ or life-threatening condition or serum creatinine more than 5.7 or dialysis dependent, you could consider plasma exchange. If the patient is controlled or the patient is on remission, you can start maintenance therapy. So you can switch to azathioprine and taper glucocorticoid, or continue rituximab and taper glucocorticoid. Then you can taper azathioprine for a duration of 18 months to 4 years, or you can stop rituximab, and the patient could be off drug in remission and in follow-up. So about kidney prognosis and treatment response. So there are a poor outcome predictors if the patient is older age, if he have a higher serum creatinine presentation, especially if he is dialysis dependent, if the patient has pulmonary hemorrhage, if the patient has BR3 ANCA, so he have more extrarenal organ manifestation, especially respiratory tract, and he have higher relapse and mortality. And there are factors in renal pathology which reflect on poor outcome, like if the patient has glomerulosclerosis, if the patient has tubular necrosis or tubular atrophy. And the remission is the absence of manifestation of vasculitis, and better to be assessed using a validated scoring system such as Birmingham Vasculitis Activity Score. Remember that kidney recovery can be seen in the face of advanced kidney damage, and the induction treatment should not be withheld based on unfavorable histologic finding. And you can have is the guide what's the guide for you for the patient response. So stable or falling creatinine, control of extrarenal disease, or normalization of inflammatory marker, all of them could be a guide that the patient is responding. And in case of poor response, exclude other causes of AKI, and you could consider repeated kidney biopsy. Histologic activity is unlikely in absence of hematuria, and during follow-up, persistent proteinuria can reflect disease activity or chronic parenchymal damage. Significance of persistent hematuria is unclear, but return of hematuria after initial resolution may indicate kidney relapse. So, ANCA-associated vasculitis is a relapsing disease. 25% to 50% of patients will experience a relapse. But the good thing is, relapse could respond to immune suppressive with a similar response rate as the initial presentation. And you can diagnose this relapse based on clinical or pathological evidence. Patients with BR3 ANCA and respiratory tract disease, they had more than threefold risk of relapse compared to NPO ANCA. And the patient with relapsing disease should be reinduced, preferably with rituximab, because cumulative dose of cyclophosphamide should be considered. And there are factors that increase the relapse risk. So, in baseline factors, patient who is diagnosed with GBA, or patient who have BR3, or patient who is more extensive disease, or patient who has ENT disease. And there are factors after diagnosis if the patient has previous history of relapse, and if the ANCA is still positive at the end of induction, and if there is rise in the ANCA. And there could be treatment factors. So if the patient has early glucocorticoid withdrawal or immunosuppressive withdrawal, or he has lower immunosuppressive exposure, all these factors can increase the patient risk for relapse. Some patient could have a refractory disease, but before you can say that it is a true treatment failure, you should exclude drug non-adherence or concomitant morbidities or secondary drive for vasculitis, such as malignancy, drugs, or infection. Remember that progression of kidney failure can reflect chronic damage and does not necessarily active disease. And in this regard, kidney biopsy can be considered to assess if the increase in kidney function, if the increase in serum creatinine or the decrease in kidney function, is it due to ongoing activity or it is due to ongoing chronic damage or chronic damage that has already done. Refractory disease can be treated by increased glucocorticoid, adding rituximab if you started with cyclophosphamide or using both of them, or you can use plasma exchange or Avacopan. In severe kidney disease, combining 4-weekly infusion of rituximab and 2 IV cyclophosphamide pulses with glucocorticoid might be an alternative to IV cyclophosphamide. And this is what we know about from the rituximab trial. If the patient is end-stage kidney disease, he could have renal transplantation. So renal transplantation is not contraindicated. You just delay transplantation until the patient are in complete clinical remission for more than 6 months. But don't depend on ANCA assay. ANCA assay results should not delay the transplantation. And ANCA, if the ANCA are positive, this does not increase the risk of recurrence. And the frequency of recurrence in ANCA-associated vasculitis is quite low. So we have 2 more slides about Avacopan. So Avacopan is the first therapy to be developed with ANCA-associated vasculitis as the primary indication. It was approved by FDA in 2021 and by EMA in 2022. It is an oral complement 5A receptor antagonist, and the complement 5A is an alpha-toxin generated following complement 5 cleavage in the complement cascade. C5A it mediates multiple pro-inflammatory processes, including activation of the neutrophil, so it could be effective in treating ANCA-associated vasculitis if we block the C5A receptor. So when we use Avacopan after induction by cyclophosphamide or rituximab in severe granulomatous polyangiitis or patient with microscopic polyangiitis, this is what we tested in the Advocate trial. And severe was defined as at least one major or three minor items of disease activity using Birmingham Activity Score. The recommended dose of Avacopan is 30 mg. That means 3 10 milligram capsules of Tavenus twice daily, and you could have it with food, but the annual cost is quite high. In Advocate trial, patients with active severe GPA or MPA received either 30 mg Avacopan twice daily until trial end, or daily prednisone 60 mg per day tapered to discontinuation at week 21. And the key exclusion criteria were eGFR less than 15 ml per minute and the patient was pulmonary hemorrhage requiring invasive ventilation. This means that in those patients we have not tested the Avacopan. The mean total equivalent dose of glucocorticoid in the Avacopan group was about less than half of the cumulative group in the prednisone group. Then the treatment with Avacopan was non-inferior to standard prednisone taper at inducing remission at the 26 weeks, but it was superior at sustaining remission at 52 weeks. So, in view of financial consideration and the lack of long-term safety data, some people think that we should only use Avacopan in patients likely to gain the best interest, the best benefit for them. In patient with active severe granulomatous polyangiitis or microscopic polyangiitis, patients who are at the greatest risk of glucocorticoid toxicity, and we have to use glucocorticoid minimizing protocol. So in this patient, you could use Avacopan. So like patient with high infection risk or pre-existing diabetes mellitus or psychiatric disorder, patient with cardiovascular disease or osteoporosis. In patient presenting with severe kidney dysfunction, particularly if the GFR between 15 and 30 ml per minute, if the patient has severe active ANCA-associated vasculitis, which is refractory to treatment, including high-dose glucocorticoid, cyclophosphamide, rituximab, and plasma exchange. So, ANCA-associated vasculitis treatment has drastically changed ANCA-associated vasculitis from a disease with about 80% mortality to a relapsing remitting disease. But nevertheless, we still have long miles to go. We are heading towards a precision medicine, putting into consideration the severity, the type of ANCA-associated vasculitis, and also the patient condition while choosing the best induction and maintenance protocol. I hope this video will be beneficial for you, and thank you for listening.